So thank you to Matt and Rajiv for asking me to speak today. Similarly to what the first speaker said, it's really nice to be back in a room full of people. I've been on maternity leave for quite a while, and so this is the first time in an awfully long time that I've been able to be in a room with people to discuss issues related to heart failure, so thank you very much for organising this. I've been asked to speak about the importance of early diagnosis, and as Sarah so eloquently puts, those delays in diagnosis represent a significant missed opportunity to intervene, to potentially improve outcomes for heart failure patient, and also to avoid that distressing experience that Sarah had where her symptoms just perhaps weren't taken quite as seriously as they could be, and the huge impact that's had. So heart failure is a costly, common clinical syndrome affecting 1 to 2% of the population in the UK. There are over 1 million patients in the UK living with heart failure, and it's a significant expense for the NHS. The annual cost of heart failure to the NHS represents about 2% of the total budget. That's a cost of over £2 billion per annum. Heart failure related admissions represent 1 in 20 of all admissions to hospital. The mortality, despite significant advances in heart failure management, it remains a condition with high mortality. 50% of patients who are diagnosed with heart failure will die within 5 years of diagnosis. And actually, that's more significant than the mortality from many cancers. But I think some of us feel within the heart failure community that there's so much tension on perhaps the mortality and the support that needs to be given to patients experiencing cancer. And perhaps historically, there hasn't been that same focus on heart failure patients. And heart failure is common now, and the prevalence is only going to increase. We have an ageing population. There is, rising numbers of patients with obesity, diabetes, hypertension. And as our treatment of ischemic heart disease has improved over the past few years, survival from coronary events has improved, but often those patients go on to develop heart failure. So we're going to see a significant increase in the number of patients who have heart failure, and we really need to focus on how we're going to get them the best possible experience and improve their outcomes. So, there are over 100,000 admissions per year to hospital with heart failure, and this represents a significant part of the cost associated with heart failure. It's estimated that the cost of those admissions per year is around £400 million. And we know that there's been a sharp increase in the number of heart failure admissions over the past 5 years. They've increased by around a third. Now, when we compare that to the increase in all other admissions, that's been about 11% over the same period. So we know there's been a sharp increase in heart failure admissions over and above the increased presentations that we've seen with other conditions. Heart failure patients tend to stay in hospital for a significant period of time when they're admitted. The average length of stay is around 10 days. And if we compare that to the average length of stay for other conditions, which is around 5 days, a patient with heart failure who has hospital admission is in hospital for at least twice as long as other patients. It has a huge impact on the patient and the healthcare system. There is a huge focus across the healthcare system on readmissions and what we can do to prevent them. But we know that a quarter of patients with heart failure after a heart failure admission would be readmitted within 30 days. And they do have associated worse outcomes with that. I mentioned the high mortality associated with heart failure, despite those advances in medical treatment. For patients admitted to hospital with heart failure, a quarter of them will die within a year of that admission. And because we're here to talk about the Cheshire Merseyside heart failure pathway, I just wanted to set the scene for what's going on locally. So we know there's around 3,200 patients that are diagnosed with heart failure across Cheshire Merseyside. The prevalence is a little higher than the national average, which sits around 0.9%. The prevalence for Cheshire Merseyside is around 1.2%, but across the CCGs there are significant variations in the prevalence, and it's not clear whether that's related to socio-economic factors or perhaps it's related to rates of diagnosis. The cost locally of heart failure is around £12 million per year. Now, we know that around a quarter of patients with heart failure are undiagnosed. So if we look at our patient population across the region, that probably means we've got around 6,000 patients across Cheshire Merseyside that have heart failure but do not have a diagnosis. Sarah mentioned in her patient story that she was admitted to hospital and that a significant number of patients received their diagnosis in hospital. We know from the studies that around 8 in 10 patients with heart failure are diagnosed in hospital. Around 50% of those patients, the first mention they get of a potential heart failure diagnosis is in the A&E department. And we all know that diagnoses in the A&E department just don't have the time and the sensitivity that we would perhaps like when explaining a life-changing condition. We know that patients who are admitted to hospital have worse outcomes, they have higher mortality. So we need to look back and see, were there earlier opportunities to intervene? For those 8 out of 10 patients that were diagnosed in hospital, 4 out of 10 of them had presented to the GP in the preceding 5 years with symptoms of breathlessness, fatigue, edema. And those patients could have had further investigations that may have led to an earlier diagnosis. And we know that by diagnosing patients earlier, we improve outcomes. And Sarah mentioned the worry that she experienced having these symptoms, perhaps feeling that she wasn't listened to, not having a satisfactory diagnosis. This is a hugely stressful and traumatic time for patients. And by assessing them earlier, focusing our investigations, we can perhaps help relieve some of that stress and worry and uncertainty for patients. Now, one of the reasons, a significant reason why a heart failure diagnosis is often delayed is because symptoms are non-specific. So the 3 most common presenting symptoms of heart failure, shortness of breath, ankle swelling and fatigue, are absolutely non-specific, and that can make it very difficult sometimes to pin down exactly what's going on. Sarah mentioned that she was diagnosed with a chest infection with post-viral fatigue, and we know that frequently heart failure patients experience an initial misdiagnosis. Commonly they're told they have chest infections because they're suddenly short of breath, they have asthma, reflux. Younger patients are much more likely to be told their symptoms are related to anxiety and depression rather than heart failure. And actually, that misdiagnosis is far more common in women and younger patients. Patients are often told that their shortness of breath and their exercise limitation is related to aging or weight-related lack of fitness. We know that heart failure patients are highly comorbid. A third have diabetes, a fifth have COPD. And because of that symptom overlap, it's more challenging both to manage their symptoms and also to establish that initial diagnosis. And this just shows that for heart failure with reduced ejection fraction patients and heart failure with preserved ejection fraction patients, their number of comorbidities. And I don't know if it projects very well, but you can see that green bar, which is the larger proportion of patients, have 2 to 3 additional comorbidities. So we're here to talk about the launch of the Cheshire Merseyside heart failure pathway, and this is taken directly from the pathway. And I really like this flow chart because we've said it's difficult sometimes to try and tease out that diagnosis from the breathless patient, but this really gives you the tools to help focus your investigations and management to try and make that diagnosis earlier. And why does it matter if we have to wait to make that diagnosis? Well, we know that mortality remains high. We know that there is a significant patient impact for a delayed diagnosis. And if we can make that diagnosis earlier, we potentially reduce the morbidity, the mortality, and the costs associated with heart failure. And making that diagnosis earlier allows patients to access treatment which can improve their symptoms, improve their quality of life, and improve their outcomes. I mentioned before, there are significant inequalities in heart failure diagnosis. We know that women wait 5 times as long to be diagnosed with heart failure as men. We know that patients from various ethnic groups, patients from a lower socioeconomic group, and younger patients, again, they all have to wait much longer for that diagnosis. And we need to be aware of these inequalities in the diagnosis of heart failure. And as a healthcare system, we need to work towards reducing these inequalities. Now, some people say, well, the patient is breathless, but they're doing okay. So if they wait a little bit longer, it's not going to affect their outcome. Well, that couldn't be further from the truth. And we have this myth of the stable patient in heart failure, the patient who is breathless but is managing reasonably well with their ADLs, isn't in hospital. And I think there's that perception that we have more time to get it right with that patient. But we know that heart failure is a condition that has a high risk of disease progression, high mortality and high morbidity. And patients who are perceived to have mild symptoms are still high-risk patients. We know that sort of delay in implementing appropriate management and indeed making that initial diagnosis leads to a delay in them receiving appropriate heart failure medications. So we are adversely affecting their long-term outcome by that delay in making that diagnosis. And those stable patients with NYHA2 class symptoms, 10% of them will have a admission with decompensated heart failure or cardiovascular death every year. So this myth of the stable patient shouldn't reassure us. Those patients are still high risk, and we need to make sure that we're offering those patients the best possible management. So when I think about my own heart failure patients, I have two key goals. I want to make them feel better. So I want to improve their symptoms and their quality of life. I want to improve their prognosis. I want them to live longer and have fewer hospital admissions. But to do that, we need a rapid, accurate diagnosis. So we know there's been substantial advances in heart failure management over the last few years. The standard of care for heart failure treatment 5 years ago, 10 years ago, is not the standard of heart failure treatment today. And the 4 pillars of heart failure management are an ARNI, BEAT blockers, MRA, and SGLT2 inhibitors. And we see the benefits of those treatments early. We potentially see improved patient outcomes within 30 days of starting those treatments. And it's really important to just acknowledge how significantly these improve prognosis for patients with heart failure. We know that it reduces the absolute risk for all-cause mortality from 35% to 10%. The relative risk is reduced by 73% over 2 years. That's an absolute risk reduction of 25.5%. The number needed to treat with quadruple therapy to save 1 life is 3.9. So if we treat 4 people with gold standard heart failure medication, we will save 1 life. And to me, that's a really impressive number needed to treat. If we think about the number needed to treat for other treatments that we push in cardiology, very few are as significant as this. But I think we sometimes underestimate just what a huge impact good medical management has for our heart failure patients. And by delaying treatment, by taking a long time to up-titrate these therapies, we are exposing patients to increased risk. Now, we know historically there's perhaps been that lack of dedicated focus on heart failure. There perhaps hasn't been the same funding available to manage heart failure, which is why it was great a couple of years ago in the NHS long-term plan to see heart failure acknowledged as a priority, the need for increased resources, the need for more structured pathways for heart failure patients. We know that historically one of the barriers to making an early diagnosis of heart failure has been that delay between initial presentation and referral to specialist services. Now, Sarah mentioned the use of NT-proBNP. NT-proBNP is a simple blood test that can effectively rule out heart failure, and it's critically important when we're assessing patients in the community for heart failure. The cost of an NT-proBNP is less than £30, and it also helps us it helps guide us as to which patients need those more costly investigations. The cost of an echo is over £1,000. And more than the cost, it's a lack of capacity and availability. I don't think my trust are unique in having significant staffing issues with the cardiac physiologists, and this is essentially a national crisis. We need to be focused in the patients that we're sending for echo, and the use of NT-proBNP helps us with that. So again, this is taken from the pathway, and this is just a beautifully streamlined flow chart that shows us how to investigate in the community those patients with breathlessness that we're suspecting heart failure. It talks about the importance of NT-proBNP and also how we can use that to then streamline our other investigations, at what point we need to refer for an echo, and the time frame in which these patients should be seen in an assessment clinic. Now, given that everything that's gone on in the last couple of years, I do think it's important just to acknowledge the impact that COVID has had on our services. Again, I don't think we were unique at My Trust in that at the start of the pandemic, many of our heart failure staff were redeployed. Our heart failure services were effectively depleted. We know that in the community, patients felt less confident accessing healthcare. They were worried about exposing themselves to increased risk. We know that across cardiology, as with other specialities, there's been a significant increase in waiting times, and we've had an increased number of late presentation of patients with heart failure. We just need to be mindful of the significant pressure that everyone has been under over the last couple of years, and particularly the impact this has had on patients. And I mentioned before, there are probably a quarter of patients that are undiagnosed with heart failure. Given the events of the last 2 years, there may be more locally, and that makes it even more important that we're focused on early diagnosis of heart failure patients. So, we need to make sure that we make heart failure diagnoses swiftly and efficiently. We're launching the Cheshire Merseyside heart failure pathway today, and that really guides on how to make a rapid diagnosis of symptomatic patients. We know that establishing patients on gold standard heart failure therapy saves lives. It improves their outcomes, it improves their quality of life, and it's critically important that we identify those patients who are at risk and we make that diagnosis as swiftly as possible. Thank you.